Welcome to this Step 3 Neurology review from Roadmap to Residency. Today is not about relearning stroke, seizure, meningitis, and headache from the ground up. It is about how the computer-based case simulations and the multiple-choice stems are written, and how to attack them under time pressure. Neurology cases on Step 3 reward the doctor who acts fast when the clock matters, who protects the airway and the vital signs first, and who orders the right test in the right order. Keep your question bank and a trusted review resource open beside this video, because these patterns stick only when you practice them. Let us begin. Here is our plan for the neurology cases. First, we will learn to recognize the high-yield stems for stroke, seizure, meningitis, and headache, because the same 4 or 5 presentations show up again and again. Second, we will attack each vignette by asking 2 questions on repeat. What is the next best step, and what is the next best test? Third, we will walk through several multiple-choice questions together and reason out loud about why every single option is right or wrong, since that habit is what separates a good score from a great one. This video assumes you already have baseline neurology knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy for neurology is to anchor on the clock and the vital signs before you do anything else. Start with the time of onset. For any sudden focal deficit, the last known well time is the most important number in the stem because it decides between clot-busting medication, clot retrieval, or simply supportive care. Train yourself to find that timestamp first, every single time. Then check stability. Look at the airway, the breathing, and the vital signs before you commit to a diagnosis. A patient who is actively seizing, a febrile patient who is barely responsive, or a stroke patient with a dangerously high blood pressure may need to be stabilized before they go to the scanner. On this exam, the calm, safe next step usually beats leaping straight to the most advanced test. Strategy 2 is to never delay the time-critical move, and this is where neurology cases separate the strong test takers from the rest. First, understand that treatment can come before confirmation. When you suspect bacterial meningitis, the exam wants antibiotics and steroids given promptly, not held hostage while you wait on the scan or the spinal fluid. When a stroke falls inside the treatment window, the clot-busting decision cannot wait on non-essential labs. If an answer choice delays a life-saving action to gather information you do not truly need yet, that choice is almost always the trap. Second, order your tests in the right sequence. Imaging of the head often comes before the spinal tap when there are signs of raised pressure, and blood cultures are drawn before the first antibiotic dose whenever doing so does not slow down treatment. The best answer respects both the right test and the right order. Let us talk about choosing the right neurology test, because sequencing shows up in a huge share of these questions. First, for a sudden focal deficit or the worst headache of a patient life, the first imaging is almost always a non-contrast scan of the head. It quickly tells you whether you are dealing with bleeding or a clot, and that single distinction decides whether clot-busting therapy is even possible. Reach for it before the more advanced studies. Second, use the spinal tap for the right presentation. When meningitis is suspected, the spinal fluid gives you the diagnosis. When a sudden severe headache looks like a bleed but the scan is clean, the spinal tap searching for blood breakdown pigment is the classic next move. Third, beware the tempting overkill answer. The writers will dangle an immediate angiogram or a full body scan that does more than the patient needs at this moment. Ordering the advanced study out of order is wrong just as often as doing too little, so choose the proportionate next step. Here is our first practice question, and it is built around the stroke clock. A 70-year-old man arrives 90 minutes after his wife watched the sudden onset of right-sided face and arm weakness with slurred speech. He is awake, his blood sugar is normal, and his blood pressure is 160/90. A non-contrast scan of the head shows no bleeding. The question asks for the most appropriate next step. Notice the 2 details that matter most: the time since onset and the clean scan with no bleeding. Read the 4 options, pick your answer, and we will reason through every choice on the next slide. Let us break this down. First, spot the pattern. We have a sudden focal deficit that started 90 minutes ago, which is comfortably inside the clot-busting window. The scan shows no bleeding, and the blood sugar is normal, so the common stroke mimics are off the table. This is an acute ischemic stroke that qualifies for treatment. Second, apply the rule. For an eligible patient inside the window with a clean scan, the next best step is intravenous clot-busting therapy, because every minute of delay means more brain lost. Third, Eliminate the wrong answers. Ordering brain magnetic resonance imaging first burns the window on a study you do not need in order to act. Starting aspirin and observing only undertreats a patient who qualifies for clot-busting medication. Aggressively lowering that blood pressure is a mistake, because a pressure of 160/90 is actually permissive for treatment, and dropping it hard can worsen the injury. The correct answer is to give intravenous clot-busting therapy. Here is our second practice question, and it is all about not delaying a time-critical treatment. A 20-year-old college student arrives with 1 day of high fever, severe headache, and a stiff neck. She is drowsy but still answering questions, and she now has new confusion. There are no focal deficits, and importantly, the eye exam shows no swelling of the optic discs. You strongly suspect bacterial meningitis. The question asks for the most appropriate next step. The key tension here is the order of operations, treatment versus testing. Pick your answer, and we will reason through every option on the next slide. Let us break this down. First, check who can safely skip the scan before the spinal tap. The STEM gives you the reassuring findings on purpose. There are no focal deficits, there is no swelling of the optic discs, and she is drowsy but not deeply unresponsive. Together, that means there is no signal of dangerously raised pressure, so the spinal tap can go ahead without imaging first. But the larger lesson is that none of this should delay antibiotics. Second, give treatment right away. The correct sequence is antibiotics and steroids now, then the spinal tap, because in suspected bacterial meningitis, every hour of delay raises the risk of death and disability. Performing the tap first and holding antibiotics for the results wastes time. Ordering brain imaging before any treatment delays care when there is no sign of raised pressure. Observing overnight is frankly dangerous. The correct answer is to give antibiotics and steroids now and then perform the spinal tap. Let us talk about time management, because this exam is a 2-day marathon, and pacing is where many strong test takers lose points. There are 480 questions in total spread across 2 days, with day 1 carrying more questions than day 2, and each day broken into timed blocks. That gives you a little over 1 minute per question on average. First, know the clock and the pace, and practice at that speed in your question bank, so the rhythm feels automatic on test day. Long neurology vignettes are especially tempting to overread, so train yourself to grab the last line first. Second, learn to flag, move on, and bank time. If a single question has stalled you for more than about 90 seconds, lock in your best guess, flag it for review, and move forward, because letting one long stroke or seizure vignette swallow the time of 3 other questions is how blocks go unfinished. Bank the seconds you save on the quick questions, and use your scheduled breaks wisely so you arrive at the second day rested and focused. Here is our third practice question, and it rewards knowing what a first seizure actually needs. A 25-year-old healthy man has a first witnessed generalized convulsion that stops on its own after 2 minutes. By the time he reaches you, he is fully alert with a normal neurologic exam. His blood sugar, his sodium, and his other basic labs are all normal, and he takes no drugs. The question asks for the most appropriate next step. The trap here is doing too much or too little for a single, self-limited first seizure. Think about what workup a first seizure deserves, choose your answer, and we will reason through every option on the next slide. Let us break this down. First, spot what a first seizure actually needs. This is a single unprovoked seizure in a healthy young adult who has recovered completely, with a normal exam and normal basic labs. The job now is to search for an underlying cause, not to commit him to lifelong medication. So the right next step is outpatient brain imaging together with an electrical brainwave study, because those results are what decide whether he even needs treatment. Now the key distinction between the wrong answers. Starting a daily lifelong seizure medication right away is doing too much after a single event with a normal exam. Admitting him for continuous medication by vein treats a seizure emergency that he simply does not have. Reassuring him that no workup is needed swings too far the other way and could miss a serious cause. Every wrong choice leans too far in one direction. The correct answer is to obtain brain imaging and an electrical brainwave study as an outpatient. Here is a high-yield exam pearl that ties the headache cases together, and it is all about red flag words. Every headache stem is really a hunt for danger words. The worst headache of a patient life points you toward a bleed under the lining of the brain. Fever with a stiff neck points toward meningitis. A new headache in an older adult with jaw pain when chewing and tenderness of the scalp points toward inflamed temporal arteries, which needs prompt steroids to protect vision. Any headache that is sudden, brand new, or comes with neurologic deficits should push you to image the head and work it up. Now the flip side. When none of those danger words appear and the neurologic exam is normal, the STEM is almost always describing a benign primary headache, such as migraine or tension type. In that case, the exam wants you to treat the headache and reassure the patient, not to order a scan. A scan ordered for a classic migraine with a normal exam is the overkill trap the writers love to plant. So recognize it and choose treatment instead. That wraps up our neurology review for Step 3. Remember the core ideas we covered today. For stroke, anchor on the clock, confirm there is no bleeding on the scan, and give clot-busting therapy when the patient is inside the window. For meningitis, never let testing delay treatment, so antibiotics and steroids come first. For a first seizure in a recovered adult, work up the cause as an outpatient rather than starting lifelong medication. And for headache, hunt for red flag words, and when none appear with a normal exam, treat rather than scan. The best way to lock all of this in is to drill questions and computer-based cases under timed conditions and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.